right, welcome. I'm like, are we live? Are we live? uh, Hi, I'm Deborah Furholden. I'm here with this is funny. We literally just had this up. I'm here with three of my great colleagues today, two of my great colleagues today, Dr. Renee Branch Kennedy and uh, Debbie. Debbie, I don't even know exactly how to say your name.
Adipolo.
The K is silent.
Oh, Adipolo.
Yes.
Wonderful. Thank you.
Thank you.
I should have asked that. We're going to talk about addressing racial disparities in health outcomes. Um, uh, I'll let my colleagues quickly introduce themselves.
Thanks, Deborah. So yes, I'm Renee Kennedy. I have the privilege of serving as the CEO at MPHI, which is the Public Health Institute located in Michigan, although we are nationally engaged. And prior to that, served as the health officer and director of the Ingham County Health Department.
Thank you, Deborah. And I'm Debbie Adipolo, and I am the Director of Health Equity and Social Justice with Michigan Primary Care Association. It is a membership organization of federally qualified health centers. And I have had the great opportunity of serving as the Deputy Health Officer for Ingham County Health Department. I recently retired after 32 years.
Gotcha. Well, I always joke my colleagues about failing retirement. So we're glad that you're still out on the forefront, doing the good work and having these important conversations. It's really great to have you. So I'm Deborah Furholden. I'm the Associate Dean for Public Health Integration at Michigan State University. You'll notice my Spartan head has Flint on the inside, a little map of Flint. We have this really great campus here in Flint. So I'm going to go ahead and get started. We were posed with 3 questions. And what we decided to do, and probably any one of us could have answered all 3 of the questions, but what we decided to do is to sort of break them down, and then we're going to have a little bit of a dialogue and kind of bring it all back together, and also give an opportunity to interact with you all. So the first question that was posed to us is, how do we start to break down barriers that uphold racial inequality through policy decisions? And really, what is our advice on this? And so I have this graphic, and I really love it because we talk about these terms upstream and downstream a lot. And given the audience and the ability of people to create policies and impact laws and systems, I thought this is a great way to sort of put in context. When we talk a lot about health disparities, oftentimes, people like myself say we blame the victim, right? As a researcher and as a scientist, when we have therapeutic interventions that don't work, we don't ask ourselves about how those interventions were created or the context in which they would be delivered. Instead, we look for reasons in the population and in the people for why things aren't working. A lot of the work that we do in disparities sort of follows that same model. We talk about differences that you'll see in certain health outcomes, COVID being a great example. When COVID started, we saw that African Americans were way overrepresented in COVID cases and deaths. And both Renee and I are on the Michigan Coronavirus Task Force. What was interesting is, as we started to look for why that was, there was nothing magical about race that would account for why somebody would be more likely to contract COVID. And then given that they contracted COVID, there was really nothing about race that would explain the excess death. When we really started to look, and we call it looking upstream, what are the factors that are giving rise to that? What we saw is that African Americans were more likely to have to work, as an example, during the COVID pandemic, less likely to be able to honor the shelter-in-place order, overrepresented in high-demand, low-wage type jobs. Those exposures are what gave rise to the excess cases. So there was nothing magical about being African American. It was what being African American gave rise to, which is the systematic and structural inequality that shows up in things like being overrepresented in a high demand, low wage job. We call these types of things the social determinants of health. These are the conditions under which people live and work and play and age. And we know that those things are a big driver of people's health. We talk a lot about genes and things like that. But what we now understand is that a person's zip code, where they live, is as strong, if not a stronger predictor of how long they can expect to live and the quality of life that they can expect to live as their genetic code. So now if we move further up the stream, what is it that gives rise to these, the context and the environments in which people live and work and play and age? Well, these are the systems and the laws and the policies and the funding priorities, how we spend our money. Those are the things that really speak to what opportunities people have, both for health and for health behavior. And so in our work, what we try to do is not to diminish the impact of great programs, right? Many of us have been the, beneficiary of programs in community, and everybody loves a great program. But fundamentally, we won't be able to program our way out of our problems, because the real question is, what are the upstream factors? And given who this group is, what are the systems? What are the laws and policies that shape and influence these contexts in which people live that ultimately impact their overall health? And so a movement that I started with some colleagues called Mandate Equity, I really think is a salient conversation here. And what mandate equity is, and I love this, these are all little caricatures. If you've ever seen me present in person, I love a good MSU green jacket and my red pumps. And these are two of our community partners. And what this depicts is there's a whole lot of community push, And that's our little representation of President Biden there. And you can see he's struggling really hard. He's got his sort of tongue popped out with a rope wrapped around this boulder. And what this signifies is we're calling for legislative pull for all of the community push, right? And you can see we got the beads of sweat coming off of us, because this is work. It is work. It's a lot easier to deliver programs in community to people than it is to influence the legislation and the policies that impact even things like funding for those types of programs. And so in the geology world, upstream is the source of the river. And so if you think that things flow downhill, the work that we're trying to do in really addressing these more upstream determinants of health is really going against the flow and really going against the current. And I think we can see now, even in our current state of legislative affairs, we've got nearly $7 billion stuck in our state legislature while people try to figure out what side of the aisle they want to fall on, or what they see as their priorities. But the thinking and the framing is that these laws and these policies and these systems and these structures are the real sweet spot for intervention. And now what we've understood, and it's sort of had the light shined on it in COVID, and I'm going to hand it over to Renee next, is we've got real barriers to the type of action that would help us move those things forward. So the next question is, how is the conversation around racism impacting these health policy decisions, or how should it impact health policy conversations?
And that's really such an important question. And I would submit that it's not yet impacting at a deeply authentic level health policy decisions. And so I'm going to talk a little bit about how it might, kind of the why first, and then how we can go about really deeply doing what we're beginning to call deep equity work, not just health disparities work, which is descriptive, right? It's based on measurement and observation, but really what are the values that we are advancing for the well-being and health of others. And so we've talked a lot about the pandemic of coronavirus. We also have been talking about the pandemic of racism, or the pandemic of social injustice that was happening around the same time. And so I want to show you this kind of parallel definition that when we talk about public health problems, here are some descriptions that come from the work of Howard Koch, who's a former assistant secretary of DHHS. And his research suggests that public health problems are really special challenges. One, they're enormous. They are enormous in scale. Look at how, a worldwide pandemic is enormous. Public health problems also stem from very complex and multiple causes. And so there's not one switch that we can flip and fix the problem, right? It's multiple, it's complex, it's intersected, integrated. These are problems that play out in the public, and oftentimes policymakers who are elected officials don't necessarily want to be in the midst of a public controversy, but public health problems push them into that space, push policy makers, push executives and leaders with influence and power into that place. Public health problems also impact a vast array of stakeholders. There are lots of people impacted a variety of different ways by the experience of coronavirus. And lastly, they require a long time to fix, right? So it's not going to necessarily be the life term of the grant. It's not necessarily going to be a span of the elected office and their term of office. And so how do we build systems and policies that are iterative and expand across a time frame? And if you think about racism as a continuing pandemic in our nation, we've never quite resolved the implications of racism. And I say that with passion and endearment as one who grew up in a military family. My father was career service. My brother is a West Point grad. We are deeply committed to seeing the United States get this right and lead for the world even. Racism is very similar. It's enormous. How can we fix this? It's very complicated, lots of causes. It's public, it's visual, it's lots of stakeholders. And this is going to take a long time to resolve, just as it took a long time for us to get there. But as policymakers, we really believe that if you bring intentionality to the conversation, I would submit to the dialogue. Sometimes people will say, I'm really tired of talking about this. And our response is, good. Let's stop talking about it and let's have a deeply strategic and influential dialogue to advance change. We believe that dialogue is doing. And so in the frame of intentionality, we really want people to do their own self-assessment, challenge your own assumptions. If you think you don't have any, it's because you've not thought deeply enough. We all have them. We've been socialized in this country to a worldview, and it's been a worldview that has not necessarily benefited all of us. And so as we advance that, looking at that person in the mirror, as they say, is an important step to being intentional. Secondly, we've got to honor people. We've got to trust and remember that trust and respect are earned. They're not given. They're earned by the relationships that we build with others. So that's that interpersonal domain, and understanding that people are going to make decisions based on what they understand to be in their best interest for themselves and for their families. So this can't be one size fits all. We've got to look at and have policies that can be applicable in diverse circumstances. Also understand that the choices people make are determined by the choices that they have. Those are institutional implications of your policies. How are we making the healthiest choice the easiest choice? Because it is not in this current moment. And lastly, how do we build systems that are going to allow us to share power? How do we engage both the workforce? How do we empower staff to, like with that boulder, to push up and to lead up to senior executives? How do we authentically embrace and include the voice of community and those who we're serving, our constituents and our customers, or whichever C word you want to use? And how are we as leaders setting a tone that allows for change and gets us out of the business as usual space? Because policies steeped in business as usual have not benefited us from a population health and a population well-being perspective. So our last question pulls us more directly to the COVID pandemic. How has the pandemic impacted those conversations?
Well, thank you. I think my colleagues hit on some of really the things that have really impacted COVID. COVID pandemic has brought about social and racial injustice and inequality to the forefront. Really, it was almost like there were two pandemics. The pandemic of COVID in itself, and then you have the pandemic of racial inequality that's really come to light as a part of the pandemic and of this time. It has highlighted that health equity is still not a reality, as COVID-19 has unequally affected many racial and ethnic minority groups, putting them more at risk of getting sick and dying. And we know that's exactly what happened, is that more people of color died, more people of color became sick as a result. And so this has really come to the top and has shed a light. When we think about health, oftentimes we think that health is something that we ourselves can determine by just eating good vegetables and getting some exercise. But we know that health is more than just that. Health is about where we live, work, and play. And that's exactly what COVID highlighted. COVID highlighted that if you were a frontline worker, you worked in industry where you had to go to work, you didn't have opportunities to shelter in place, that you had greater exposure. And that's exactly what happened. And so we see that. And I think both of my colleagues have really talked about how we need to look at access and opportunities for all people. And one of the things that I keep asking myself are some questions that I think that we should ask ourselves. What are some of the system-based solutions that we need to come up with? We need to have this recognition that racism is manifested in power and control of resources. We need a focus on both personal transformation and structural change so that racist practice and policies can be detected, confronted, and prevented. And individuals need to, with collective action, we need to do something with this collective action at the individual level and at a collective level. There needs to be some vigilance and comfort with discomfort. I think that that's really important. It's hard to have the conversation when we begin to talk about race. It's sort of like everybody needs to run to the restroom. But now it's time that we have that uncomfortable conversation. There needs to be this unlearning and relearning of what's appropriate, what we need to have, and who needs to get what. I feel like health is one of those situations where we think that something is just going to happen, but it isn't. I remember back in 2009, folks were still affected the same with the H1N1 as we are here today with the pandemic. And yet we didn't think ahead and prepare so that we could save lives. And so many folks were lost, many Black people and people of color. Racism is a barrier to health. And so we really need to look at how do we eliminate that in health and healthcare and in the health disparities. I really like the definition of health equity provided by, I can't even think of her name right now, but I'm going to give you her definition. And she
Kamara Jones. I read your mind, Debbie. I know where you're going. It's Kamara Jones.
It is not Kamara Jones, but it's
oh, it's not.
Yes,
Margaret Whitehead.
Whitehead, yes. It's the opportunity for everyone to attain the highest level of their health potential. Achieving health equity requires valuing everyone equally with focused and ongoing societal efforts to address avoidable inequities or inequalities, historical and contemporary injustices, and the elimination of health and healthcare disparities. And we really need to think about how do we address the historical and contemporary injustices so that people today, that we can have a better life. I would hate that 10 years, 20 years from now, we have another pandemic and we find ourselves in the same place. Let us take advantage of the opportunity that the light has now been shined. And how do we now move forward? What do we do differently to ensure that we don't lose lives unnecessarily? Thank you. And so I'm going to turn it back to Dr. Verholten.
Great, thanks, ladies. And so we have some great questions in the Q&A, and we'll make sure that we leave plenty of time for that. But I love this quote. It's a quote by Martin Luther King, and it says, "Injustice anywhere is a threat to justice everywhere. We're caught in an inescapable network of mutuality, tied in a single garment of destiny. Whatever affects one directly affects all indirectly." And I think a lot of people maybe didn't realize, but COVID sort of made it inescapable. this is the impact of structural racism is one that we all bear. We've been doing some work, and Kellogg has a really great report where they talk about the business case for equity. It will have cost our nation. The new stimulus package is almost $1.9 trillion. The unnecessary cost and burden that we have paid because of all of the gaps in our system, because things are not set up so that we are able to fairly and equitably assure health for all people. This is a price that we all ultimately pay. And so I think it's an important conversation for us to have because, we always think about it, and I think about some of the work that we've done around gender equity. Gender equity didn't happen because women only decided that we wanted things to be different, right? Women are very clear about the issues that we face in inequity. And African Americans and people of color and other underserved groups, people with disabilities, people living in rural communities, they are very aware and tapped into what their lived experience is. And they're also very aware of what many of those solutions are. However, the people that hold the power are the people that we need in the conversation. The people that make decisions and control the flow of resources. This is where the real action has to happen. So I really do encourage our audience to really think powerfully. What I always say is I don't need my politician to come to my church and tell me Black Lives Matters. I need them to go to the white churches and tell them that Black Lives Matters. So I hope we can have a real dialogue and sort of open this up and really dig down a little bit deeper. If you ladies don't mind, I'm going to turn the camera off so we can have more of a conversation.
Yeah, that's great. And Deborah, as you're saying that, I want to just underscore one point, because I wanted to make it clear that although you happen to have a panel of 3 African American women, that this is absolutely not an African American problem. It is a societal problem. I'm always challenged by the word ally, although I can't figure out a better alternative. But something about ally says, I'm so nice, I'm going to come help you with your problem. Well, it's our problem. And so I really appreciate that analogy around gender, and the same is true for racism.
Yeah. And we say it's not your problem, it's not my problem. It is our problem.
Yes.
Yeah.
Well, Deborah,
all right, great,
like
ladies. So I'm going to pose some questions for you. And these are some good ones. The importance of data. Can you speak to the importance of data collection and health disparities, and how do we improve data collection? So I'll offer this initial thought. We have the ability to collect data. We know how to do that. When you saw the data that we collected initially around COVID vaccination, the initial criteria included age. So in our first 2.5 million doses that we delivered in Michigan, we had 0 missing data on age. Why? Because we had to demonstrate that we were getting it to people who were eligible. 44% of that same data were missing race, and 70% were missing ethnicity. I call that the unacceptable omission. And it's funny, Renee, because I called you and I said, this is all getting entered into the MICR database. How long would it take a programmer to make race a mandatory field that has to be entered? And I don't remember what you said, but it was something on the order of less than 30 seconds. Like, this is not, this is not major stuff. And so I don't want to pretend as if the problem is we have these completely inappropriate systems. Are there places where we can improve our public health infrastructure? Absolutely. It is an unacceptable and unnecessary omission to not require that things like race and other key demographic variables accompany these types of health data. Because without the data, one, we can't effectively quantify the extent of the problem. And that doesn't make the problem go away. Not having the data doesn't mean you don't have a problem. And then we also cannot evaluate the impact of our work. So this is an area that is important, and it's called health data disparities, the unnecessary and unacceptable omission of race and other key demographic data, poor quality data for people from underrepresented minority groups or other marginalized groups. And then a third level for that is not even considering the very important contextual and social determinants of health that should also accompany one's health data. So we've got a big opportunity, I think, to do better. And a part of it is we need people to have real skin in the game. I've been advocating for, if you don't collect race when you administer COVID tests, then you can't be a COVID test provider. If you don't collect race when you provide vaccines, I think there should be a penalty. When I was a kid and I broke curfew and nothing happened, that's what I did. I kept breaking curfew. If people can continue to kick this can down the road with impunity, they will have very little skin in the game in doing that. So we do need, I think, support from the top down. There is a policy in the CARES Act. It's a requirement that all COVID testing providers collect race data, but that law has never been enforced. It's akin to gums without teeth. So not only do we need the laws, but we need enforcement of those laws. And we need some goodwill too.
Absolutely goodwill. And on that goodwill point, I would also argue that what is data? How are we defining data? Who gets to legitimize what information is valid and what isn't? And so when we talk about qualitative data, the experiences and the stories and the narrative that people are sharing, we're also responsible for codifying and summarizing those things in a reliable way. And there are scientific methods for doing that, so that we're getting an informed, as Deborah said, contextual interpretation of the things that we can add and track and subtract, and the things that we can mathematically and empirically manipulate. But we also have to have qualitative data to frame the interpretation of all of that data. And how do we improve it? We just improve it. We do it. We make it a priority, as Deborah said.
And I just want to add, so my colleagues, they are researchers, and I would just say that data is wonderful. I've been in public health for 32 years, and we've had data, and we've known what we know today for at least that many years. So I also say data is good and it's important and we need to have it, but then what do we do with the data when we have the data? And so I do think that there has to be this both and, to collect the data and then to use the data in a way that makes a difference and a change for the lived experience of how that data is impacting folks.
Great. All right, I'm going to toss another question your way. And I'm getting a little feedback, so maybe when you're not talking, mute, and I'll do the same thing. So I'm going to throw this over to Renee, and then Renee, you can toss it over to Debbie. The COVID pandemic shined a light on these disparities. How do we keep the momentum and attention on this issue in a post-pandemic world?
Man, that is such an easy and a difficult question all at the same time. I had been saying early in the pandemic, when the social injustice events were happening around the murder of George Floyd, the headlines are going to change. The headlines are going to change. And the only way that this is going to stay front and center is for like-minded people. Martin Luther King called them other-centered men and women that are focusing on the needs of others, that will continue to say, excuse me, but this is a journey, not a destination. Like, it's not a box that we can check. We are talking about disrupting the difficulties in how we live our lives. And so it is a matter of continuing to press. And I would invite everyone who is on this webinar to sign up, to say, okay, that will be me. When I'm in a conference room with colleagues, again, whenever that might be, when I'm on a Zoom and no one says anything about the structural things that might disadvantage some populations more than others, I'm going to be the one to say, can we go back to that last agenda item? Can we think about this? Do you think this solution is going to meet the needs of everybody? And the more you begin to do it, the broader that dialogue will spread. And I can say that because when I was at Michigan State, 16 years of my career, the first I think they called me the minority advisor, and then we changed that to the social services advisor or something like that. Anyway, I was always the diversity person. And so after about 5 years in, I walked by a conference room and there were people in there talking and diversity and racism. And I'm like, oh my gosh, I'm missing a meeting because they only talk about this stuff when I'm around. And I went to the dean's office and it was a nurse practitioner meeting. I knew my work was almost done because people had owned the issue as their own.
No, I definitely agree with Renee that keeping it forefront is really saying, hey, remember, do you remember when? And I do think that we need to continue to lift it up. I feel like, however, that as the federal money goes away, we don't have all of the different things that COVID brought, being able to work from home for some. We have child care assistance. There's some special taxes. When all that goes away, it's going to take some really true hardcore people to stand up and say, hey, this was needed, not because of COVID. It's needed because people need it. And so we're going to have to continue to value and advocate one another. And I'm not as optimistic that we're going to hear somebody over there in another room talking about it 10 years from now, but I'm hopeful. I'm hoping that that's what happens, because if not, we'll be back to the same place again. And I don't want to be back here. Although I will say that when George Floyd died, I thought, okay, that this was it. But I don't know about you. I've been traumatized every night as I watched the news about some other Black person who has died. So I would say we got to keep pushing. We got to stay hopeful. But it's going to take all of us to keep pushing.
Great. We got another good one here. And it asks, are there any bills or policies moving through the legislature focused on addressing racial disparities? If not, what policies would you advise lawmakers, federal or state, to pursue? I want to lay a little bit of a foundation for this, and then I'm going to toss it around. There was a legislation that was introduced in Michigan to allow prioritization for COVID vaccine distribution based on what's called the Social Vulnerability Index. And I always remind people, health disparities and the science around how to conduct health disparities research, the work and the framing around health equity, and how to implement health equity-centered solutions is real. This is not, you wouldn't walk into a hospital with a pregnant child. My daughter's pregnant. I'm gonna be a grandma. It's like, I'd take an ad out in the New York Times if I could, but I wouldn't walk into the hospital and just let any old body in the hospital deliver my grandchild. I wouldn't even just want any physician. I want the best OB/GYN in that hospital, right? If you broke your leg, you're not going to go to the dentist to get it fixed. And the thing that I started to see is that people are maybe well-meaning or maybe well-intentioned, but really not steeped in the work of how you actually eliminate health disparities and how you move upstream in those efforts. And so what happened in Michigan is that got blocked. And there were legislators who said, we are not in agreement with this. We want these resources to go to those who need it the most and those who are at the highest risk for a bad outcome. And we know that that is older populations. So we are only willing to prioritize vaccine distributions to communities with higher proportions of 65 and older. And I thought, okay, that's very well meaning. But this is why having people like Debbie at Apollo, like Renee Kennedy, like Deborah for holding at the table are so important. Because I said to a legislator, if you do that, do you know living to be 65 is a privilege? Do you know that living in a community where you've got a high proportion of people who lived to be 65 and older, predictably, you are now looking at a privileged community? Do you know if you do that in Michigan, you're going to prioritize communities that are wealthier, that are whiter, where people have retired, bought their cabin up north and gone up north. You are being well-meaning in what you're saying, but you're not giving credence to the real, like Renee said, the lived experience of people and the expertise that those among us who've been doing this work, applying this lens, learning these approaches and applying them and have a track record of success and moving the needle, you're not giving weight to that experience. And so I'm just noticing that some of the bills and the policies and the things that we try to move forward are hard to move forward, even sometimes when you're dealing with goodwill or well-intentioned legislators, because I say equity and racial equity and health equity is a very weak and underdeveloped muscle for our nation and many of our leaders. For some of us, we've been standing on the mountaintop shouting about it for, Renee, maybe 20 years, And so, but for others, this is new for them. So what I really would encourage for legislators is lean on experts. We're here and we're having this conversation because we want to help bring this lens, bring this framing, be a thought partner and a knowledge broker with you, so that as you elevate and your ability to serve and implement the kind of policies that are really going to create contextual and systematic shifts for us, you've got real trained experts who want nothing more than to make sure that you are empowered in that work. I'm going to toss it over to my colleague.
Let me give you two examples of a success on how we know of this is on two successes Michigan has had. There was previously the requirement that if you had a history of a felony history, that you were ineligible for SNAP benefits. Those are food nutrition benefits, sometimes referred to as food stamps. Think about that. If you were formerly incarcerated and released, who needs assistance with food and healthy choices more than someone that's trying to find employment, trying to get back on track? But that was the policy and the law for I don't know how long in the state of Michigan. Our legislature reversed that. So now I am proud to say that formerly incarcerated individuals are eligible for SNAP benefits. What was the philosophical lens that went behind that? How did we just take a group of people and decide they were bad people instead of seeing a group of people who did a bad thing, but separating that from their humanity? We also successfully now are requiring that for your licensure in the state of Michigan, clinical medical licensure, you have to demonstrate that you have taken an implicit bias training. Now, that is a drop in the bucket, right? It's a first step. Debbie used the word unlearning. We've got a lot to unlearn, and we're not going to unlearn it in one session or two sessions. But what that does is sets a tone, and it says in the state of Michigan, we are putting some teeth into the fact, Deborah's gums and teeth, we're putting some teeth into it to say we mean that you are going to be intentional about not treating people differently based upon their race, their gender, their age, their class. And we are, as a workforce, a health and medical workforce, going to unify around this. There's nothing scary about these trainings. Certainly in my work, I've always said there are two rules that I have. One, we're going to keep people whole, and we're going to keep people at the table, because communities of color leave the table because they're like, I'm tired of being traumatized about this over and over again. I'm tired of ripping the Band-Aid off that painful memory, and they leave. White people leave the table because they're like, I'm tired of being accused and called a terrible person. We all rip ourselves apart. We're not submitting that is productive ways to change behaviors and build relationships. But how do we honor each other across difference, across race, across gender, so that those things are no longer subconsciously playing out in our decision-making in a deleterious way? two great successes for our state.
That's good, Dr. Kennedy. I would also just say that if we have to, legislators and others have to be real and beginning to think about our equity. How do we do that? And I think that treating people fairly often means that you're going to have to give them things differently. And so legislators are often about how do we give everybody the same thing. And so I do think that we are going to have to begin to think differently about that. How does legislators have conversations with communities to find out what those communities need? And then how do we begin to then not only legislate, but how do we provide money to allow communities to decide for themselves sort of what they might need? And I think that that would be a way that we can consider moving forward.
Unmute, Deborah.
It's the line I've heard the most during COVID. You're on mute. Okay, great. Thank you. We got time for one more question. And I'm going to start with Renee, and then I'll, Debbie, if you want to add anything. How do we see MDHHS's role in addressing health disparities as we recover from the COVID pandemic? And Renee, if I can add one little piece to it, because you're the CEO of the Michigan Public Health Institute, which works closely with MDHHS, has some distinctions in the things that you do and you don't do. So if you answer that question, what do you see MDHHS's role, and where's MPHI in this also? Because a lot of places don't have an MPHI, and it does create an unparalleled opportunity for us to do things that other places might not have.
Yeah, thank you, Deborah, for that context, because you're right. I mean, I am so proud to live in a state where our legislation, but we can't get that word out today, Debbie, can we? Where our legislators had the foresight, where our state health department leaders, this is back in the 80s, had the foresight to say, how can we bring voice to us? How can we make sure that we are representing the needs of our constituents that voted us into office, that are trusting us in leading our state health department? And so, yes, MPHI was created by legislation in statute to partner and advance the goals and priorities of the state of Michigan through the state health department. And so what I've seen is our state health department, MDHHS, is now doing what we've been trying to push for in a national initiative, which is transforming public health back to its root cause history and root cause solutions. So you'll begin to see pretty much every division, right, is talking about not what we do, but how we do it through an equity lens. Equity is not like one more little thing over here. It spreads through the context of all of their work. And so as the largest state department and as the department that has health and human service, right, well-being in its name, they're the drum majors. And they're there to represent the interest of elected officials, certainly to represent the interest of our governor, but also to advise and educate them, right? It's a bi-directional relationship. And I'm real proud that our state created a mechanism like MPHI to help advance that on behalf of our citizens.
You're on mute.
So I thought I don't have anything. So I'm going to let you wind us up.
Okay, wonderful. So this is great. And I want to really acknowledge and appreciate you both. It's interesting because as people who are doing the work in different respects, right? You both have had this experience in the local health departments. Renee is running this really transformative agency that partners not just with the MDHHS, but with many organizations and communities and stakeholders across the state. Me who, at the front lines of research and trying to really bring the real good science and innovation. We always talk about evidence-informed interventions and evidence-based interventions. And it's always funny when the practice people say, your evidence has no applicability over here. You've missed the mark. There's a big bridge between what you did in that project and what we can do out in the world. But I think these types of conversations and coming together, especially with this critical stakeholder group of legislators, is really important. So I acknowledge and appreciate both of you for all of the great work you do, and for the folks that are listening in today. Keep fighting the good fight. We are here. We are all in this together. And just like we move the needle, only state that I know of that closed the racial disparities gap in COVID is Michigan. We can do that same work and address some of these other conditions that predated COVID, and we know will be here when COVID is gone. I think that's our time.
Thank you, Deborah. Great facilitation.
Thank you. Thank you to both of you. I enjoyed it.
Any last comments or thoughts that we want to hum a tune on our way out? I thought we had a hard stop at 11:45.
I think it's 11:50. Oh.
11:45.
I will say, I'll throw in a last little bookend. You know, I just want to underscore how challenging this work is, but nothing worth having is easy, right? And so we have these dialogue agreements, and one of them is it's okay to disagree. The other one is it's not okay to blame, shame, or attack. And I would submit that we've been doing a lot of blaming, shaming, and attacking. And I really want to see us come together in solidarity for the sake of everyone. Everyone has an invested interest in this. And I hope that the State of Reform's inclusion of this in such an important meeting will also be fuel for your fire as you go back into your own spheres of influence and say, we need to see differently, say differently, and do differently for the good of others.
Wonderful. I love that. Deb, any last thoughts from you?
I would just like to add that this was a great opportunity for us to sort of lift up and highlight things that have been going on for a really long time, the disparities. Again, COVID only shined the light on what many of us in this work has known has been going on in terms of disparities. Infant mortality rates have been for Black women, for Black babies, 2 to 4 times higher than white babies. Maternal infant mortality also, about two times higher for Black moms die. And so these are things that have been going on for a long time. And I think that this is now is the time, is our opportunity to really have actionable things that we can do to make a difference. And so I'm really hopeful that as we move forward, that we will begin to see some change.
Wonderful. And the important role of community, and Renee, I think, was alluded to this a bit and when she talked about people with lived experience. Our model is that we don't do things to people or for people. We don't even do things on their behalf without their permission. Because there are times when people will say, you have the mic or you have a seat at the table. Could you represent this point of view or could you represent this interest? But you should only do that with somebody's permission. The shift in power dynamic and resources and allowing people a real seat at the table. And a seat at the table isn't just, one, for show. It's one where people have an influence on how resources are spent, on how decisions get made, on what sustainability plans look like and things like that. And so I do think it's important. And because elected officials really do reflect and represent the views of a group of people who they raise their hand to serve, I do encourage that. There should be seat for community at these tables. When making decisions about people's health, it is important that they have a voice and it not be imposed on them. Okay, so once we're done, we're done. I'm trying to read the comments. I'm going to thank you both. Thank you for your additional closing thoughts, and I'll see you out on the field of equity.